Our next session is Michael Rosbash session. It is named after the scientist Michael Rosbash, who received the Nobel Prize in Physiology or Medicine in 2017 for the discoveries of molecular mechanisms controlling the circadian rhythm. I would now like to welcome our chairpersons for this session, Dr. Pragnesh Vacharajni from Ahmedabad and Dr. Swapnil Bhavsar from Ahmedabad. I would request Dr. Pragnesh sir to please introduce our first speaker.
Good afternoon, everyone. It's thanks the organizer for giving me this opportunity to be here in this fantastic SwasthyaCON 2021. And I'm seeing the host of program since today morning, the excellent lectures going on. Our first talk today is about how can we limit the development and progression of type 2 diabetes in youth and middle age. And the speaker is Dr. Subhankar Chowdhury. Sir is DM endocrine and he has done his MRCP from UK, and he is currently the professor and head of the Department of Endocrinology at IPGMENR and SSKM Hospital, Calcutta. So I will welcome Dr. Subhankar Chowdhury for his talk.
Thank you very much to SwasthyaCON 2021 and especially to Dr. Mayur Patel and his wonderful team for allowing me to be part of this wonderful effort to deal with metabolic diseases. The remit for me is how can we limit development and progression of type 2 diabetes in youth and middle age. Of course, we are in the midst of a COVID pandemic, but we have an ongoing pandemic, endemic, epidemic, whatever you call it, of diabetes, which will continue even beyond the vaccine becomes available and we have lessening numbers of COVID-19. And it's important that we address youth and middle age, but what we shall discuss overall will be applicable probably across the different ages, but we shall try and demonstrate what issues are more applicable for the younger age group. Now, we all have learned from our community medicine days that there are different levels of prevention: primordial, then primary, then secondary, and then tertiary. However, when we talk of diabetes, type 2 diabetes prevention, and I'm now restricting myself not to type 1, but to type 2 diabetes prevention, when we talk of primordial prevention, it is essentially population-based strategies to prevent risk factor development. And what is the risk factor for type 2 diabetes? One of the most important is obesity. So preventing obesity from developing in the community itself. Primary prevention would be strategies to prevent diabetes from occurring in susceptible individuals or populations. For example, those who are obese, those who are inactive, those who possibly already are in a pre-diabetic phase, those with a strong family history of diabetes, and so on and so forth. Then comes secondary prevention. That is, once you've got diabetes, you try to detect it early enough before complications have developed, and then provide effective control so that you prevent or delay the progress of disease. And tertiary is measures taken to manage the complications of diabetes. Frankly, we are actually practicing more of secondary and tertiary prevention and less of primary and very little of primordial prevention. So if we talk of primordial prevention of type 2 diabetes, of course, there's a lot that we can talk about at the societal level, but we also should remember that the risk of diabetes possibly starts even before you are born. It starts in the intrauterine environment. And one of the important issues to address, at least in our country, is maternal undernutrition. And remember, low birth weight as well as very large birth weight predispose to diabetes later in life. So the point that I'm trying to make is it's important to address much earlier on, even before possibly the person is born, the baby is born, addressing maternal nutrition is one of the important issues. And we hear about two issues. One is the thrifty genotype, which is not our purview today, but thrifty phenotype is what we are concerned about. And we are to prevent the small for gestational age babies, and we prevent them from getting obese even in later life, which tends to give rise to a whole lot more of insulin resistance and beta cell defect. And there are guidelines for weight gain during pregnancy, and roughly we can look at a figure for women who are of average body weight, BMI, let's say 18.5 to 24.9. Average body weight, weight gain in pregnancy should be targeted about 12 kilos or thereabouts. Now we come to primary prevention, and here possibly we need to know who are especially at risk for developing diabetes and the different risk scores. We in India also have an Indian diabetes risk score based on the age of the individual, the waist circumference, physical activity, and family history of diabetes. And we know what is a low risk and what is a high risk. However, because of the overall high risk of diabetes in our country, possibly screening, at least for pre-diabetes, should start quite early, around age 30 years. American Diabetes Association would suggest at 45, but for us, because all of these events occur earlier, I would suggest we start at 30 years. And if the results are normal, then repeat testing at 3-year intervals. And even the American Diabetes Association does suggest that testing for pre-diabetes should be considered in adults of any age with overweight or obesity and who have one or more additional risk factors for diabetes. And we all know, as Asian Indians, we have this additional risk factor for diabetes. So all of us should qualify if we are overweight or obese. Now, if we think of youth onset diabetes, how to prevent, well, here also the principles are similar. So screening for type 2 diabetes or pre-diabetes in asymptomatic adolescents would be for all those who are overweight or obese. Overweight is defined in more than 85th percentile and obese as more than 95th percentile, and who also have at least one more additional risk factor, like the mother having had diabetes during that particular pregnancy through which this child was born, or a family history of type 2 diabetes, or signs of insulin resistance or conditions associated with insulin resistance, namely polycystic ovarian syndrome in girls, or presence of acanthosis nigricans, hypertension, and dyslipidemia. So these are the indications. We do see diabetes even in children, type 2 diabetes even in children less than 10 years, but clearly it's much less than we see in the adolescent age group. But even in that age group, possibly we need to have multiple of those risk factors along with obesity in order to qualify for a screening test for pre-diabetes. Now, what do we do once we find someone who is obese, who has got a high risk? Well, there is a lot of evidence that if you can bring about 10% of your body weight loss, which may be much less than reaching the ideal body weight for that individual, still it does a lot in terms of not only prevention of diabetes type 2, but also does a lot for dyslipidemia, for hypertension, for non-alcoholic fatty liver disease, and for polycystic ovarian syndrome. So this is not just for diabetes prevention, but this is for overall health improvement of the population. And we know the different mechanisms relating to type 2 diabetes, of which the best understood is still poor insulin action and or low levels of insulin. But to that, a whole lot of other issues have been added, like increased glucagon, low incretins, low testosterone, low vitamin D, and so on and so forth, so that we now talk of a dirty dozen or even more number of factors have been added to it. And our effort at getting the weight down clearly will help to improve one actually more of this dirty dozen, as we shall soon see. So we have all learned about heard about the diabetes prevention program, which was a large study in the United States, looked at more than 3,000 people and looked at lifestyle change along or versus metformin versus doing nothing beyond standard advice about diet and physical activity. And it showed that lifestyle change was very effective, reduced the risk of diabetes by about 60% compared to placebo. While it was effective across all the participating groups, both men and women, which is good news, but it was most effective for those above 60 years of age. The risk reduction was almost 70%. Metformin surprisingly didn't do as well, reduced probably the risk by 30%. However, in the younger age group, and today we are talking of the younger age group, the youth and the middle age, in that age group, possibly metformin had an edge, was more effective in this age group, 25 to 44, in women with a history of gestational diabetes and who were grossly obese, BMI more than 35. So in this age group, not just lifestyle, possibly metformin may be a good form to use to prevent diabetes. And then what about following up on these individuals who participated in the diabetes prevention program? This is the DPPOS, the outcome study. And while the study is still ongoing, supposed to follow up till 2025, the last analysis was in 2017, and it showed that it's still, the group that was in the lifestyle change program still continued to show reduced or delay in the development of type 2 diabetes, 34% reduction. If you talk in number of years by which diabetes onset was delayed, it's 4 years. The metabolic parameters were improved. Microvascular complications were less. So it's clearly effective. The important message is lifestyle change is extremely important. And then we have evidence from a whole lot of other studies from different countries, the Finnish diabetes prevention study, the very also well-known Chinese Daching study, and so on and so forth. What about India? We have our own Indian diabetes prevention program, which was testing this sort of same hypothesis in Asian Indians who, with IGT, impaired glucose tolerance, who are younger and generally leaner. But once again, it was found that lifestyle modification was effective. The degree of impact was less, about 30% risk reduction. And it was similar with metformin, or whether you combine lifestyle modification with metformin. So clearly, even in our context, there is evidence that lifestyle modification with or without metformin could be effective. And hence, the American Diabetes Association recommends lifestyle changes in prediabetes, aiming at a weight loss, a modest weight loss, about 7%, in increasing physical activity, moderate intensity physical activity like brisk walking to 150 minutes per week, and remembering that even prolonged sitting could be harmful. And so if you break this prolonged sitting at workplace, including at our own desks, at our clinics, every 30 minutes by short bout of activity is helpful. And it's also now appreciated that technology-assisted diabetes prevention interventions may be effective in preventing type 2 diabetes. And it may be more applicable to the younger age group, to the youth, who are more easily adaptable, who can more easily adapt themselves to the new technologies. And in terms of the macronutrient composition of food, we have to have carbohydrate, protein, fat, lesser saturated fat, more of polyunsaturated, even more of monounsaturated fat, less of cholesterol, zero trans fats, and enough dietary fibers. And the IDF, International Diabetes Federation, has some recommendations for a healthy diet for the general population. Some tips, for example, choose water or coffee or tea instead of fruit juice or soda or other sugar-sweetened beverages. Eat enough vegetables, enough fruits. Choose maybe some nuts or piece of fresh fruit or unsweetened yogurt for a snack, and so on and so forth. Limit your alcohol intake if at all you have to have. And then has come in recent times the appreciation of the importance of intermittent fasting. While we can't go into the details of it, there is some evidence that suggested that time-restricted fasting means you eat every day, but you have at least, say, 12 hours of fasting in between two meals, has been shown to be quite effective in helping weight loss, improving metabolic parameters, and decreasing the risk of diabetes and even some cancers. And as I mentioned that the world over, including the AIIDR, recognizes the importance of technology today. While technology, we know, has also made us more lazy fellas. We want to not get up even to change the channel on the TV. We have our washing machine. We have the lifts to go up and down the buildings. But still, technology can also help us track how much we are eating, what we are eating, how much we are exercising, and we can get important cues through technology to help us further improve our lifestyle measures. So we should now not become just servants of technology, but use technology as our servant to improve our lifestyle. And then about medications, which may be used, which has been used in pre-diabetes to prevent progression to diabetes. And here is a meta-analysis, which is not so old, in 2019, which suggests that alpha-glucosidase inhibitors have some role, GLP-1 receptor agonists have some role, metformin has a small effect, orlistat has an effect, vitamin D, we shall come to this, has been shown not to be effective in this meta-analysis. TZDs have some role. TZD plus metformin has a role. Statins do not have an effect. ACE inhibitors do not have an effect. So if we come to vitamin D, because there is so much of vitamin D deficiency amongst our population, I thought I'll highlight this part. While we have seen that there is a strong sort of negative correlation between vitamin D level in the blood and the incidence of diabetes, meaning thereby, if you have less vitamin D, you have more chances of developing type 2 diabetes. However, most studies, and including this was supposed to be the final study to decide whether vitamin D administration helps to prevent diabetes, the D2D study, which came out in the New England Journal of Medicine in 2019, showed that risk of new onset diabetes not significantly lower with vitamin D than with placebo. However, we need to remember that this study did not look at people who were deficient in vitamin D. Irrespective of vitamin D status, they gave them 4,000 units of vitamin D. We had done a small study which was published, I think, 6 years back, which did show that if you give vitamin D to impaired or pre-diabetic individuals who were insufficient or deficient for vitamin D, there is a definite evidence that vitamin D prevents the progression to type 2 diabetes. SGLT2 inhibitors, I just thought I'll bring this up because of this recent paper by Insuki, which is derived from the DAPA heart failure study, which, remember, looked at people irrespective of their diabetes status. And they found that people who had got dapagliflozin and who initially had pre-diabetes had much less progression to frank diabetes. So maybe SGLT2 inhibitors could in future be also be considered in the context of prevention of diabetes. Bariatric surgery, which leads to very marked weight loss, has also been shown to help prevent diabetes, has also been shown to even cause remission of established diabetes. We won't have the time to go through the mechanisms involved, which could be short-term and the long-term. Remember, much of the benefit can be seen even in a short term, within a few days or weeks of the surgery, while the weight loss takes a little while more to manifest. But by alteration of incretin activity, adipokine activity, decrease in portal lipid influx, and so on and so forth, and possibly through changes in gut microbiota, you can give rise to resolution of diabetes, which is generally considered to be much more effective than a medical treatment. and the weight loss is clearly much more impressive than medical treatment. However, we need to remember that people who are relatively younger, people who are more fat, who have better beta cell preservation, and importantly have a shorter duration of diabetes, tend to have more effect of bariatric surgery in terms of remission of diabetes. And so that brings us to the very important concept that when we talk of beta cell loss, possibly it's not a total death of the beta cells, but possibly it's a de-differentiation of beta cells, which can be brought back to their functional status by various mechanisms, including significant weight loss. And we have for that evidence even from medical intervention for weight loss. And this was a very elegant study by Dr. Roy Taylor and his group in Newcastle upon Tyne, the direct study, which again showed significant initial weight loss followed by maintenance of that lost weight could lead to remission of diabetes. Of course, in a relatively small group, subsequently has conducted that in a bigger group, about 300 individuals. And so it does give us sort of hope that there can be the progression of diabetes could be modified not only by medications, but importantly, even by significant lifestyle changes. And so these are the various mechanisms by which we could have got type 2 diabetes. And these are the various points where weight loss, insulin sensitizers, GLP-1 receptor analogs, bariatric surgery, DPP-4 inhibitors, vitamin D, yoga, SGLT2 inhibitor could all intervene. And so I would like to finally conclude by saying that we as physicians are quite attuned to tertiary prevention and even secondary levels of prevention for type 2 diabetes. But the clear message today is that we need to shift to primary, even better to primordial levels of prevention, which, however, would require significant contribution of the government, of the society as a whole, to get into the act. Still, lifestyle modification with or without metformin remains the cornerstone. And while we say prevention is better than cure any day, that's correct, but it's not always that easy. Thank you very much for your patient listening.
Thank you so much, Dr. Subhankar, sir.